Hello, let me introduce myself. I am Stappler. I am a consultant vitreoretinal surgeon at the Royal Liverpool University Hospital, and I want to introduce you to Siluron Xtra and Siluron 2000 novel molecular design tamponades for vitreoretinal surgery. No new developments have happened for the past decades in silicone oil. However, the surgical environment has changed significantly. The surgical handling has become more difficult as we work with ever smaller gauges. Emulsification remains a problem as it is responsible for inflammation, glaucoma, and perioral fibrosis, which can lead to retinal redetachment in its own right. There is also a lack of accurate and reliable measuring techniques. I want to show you how by altering the molecular design, we are improving the rheology to obtain faster injection through existing gauge and injection through smaller gauges. Oils also have increased emulsification resistance by altering their extensional viscosity. We will present to you novel in vitro methods of quantifying emulsification, and we will also report on the first of its kind RCT comparing the emulsification of two different silicone oils. The aim is to change the oil's behavior from Newtonian to non-Newtonian, inasmuch as the lower shear viscosity at high strain rates provides for faster injectability, that's called shear thinning, and a divergent extensional viscosity adds emulsification resistance. The solution is to add a small percentage, 5 or 10%, of very high molecular weight silicone oil, in that case 2.5 million chain lengths, and these long molecules are supposed to entangle the shorter chains to prevent and reduce small droplet formation, which is the mechanism by which emulsification happens at the interface. The advantage is that high molecular weight silicone oil is not a new chemical substance. It might be very viscous, but it is the same as your normal silicone oil, and it is on this basis that CE marking was awarded. This leads to faster injectability, faster injection in 20 gauge, in 23 gauge, and through different machines. And this amounts up to a third reduced injection time across the gauges. And you can model this by having viscosity matched silicone oils made up that are either 2000 to match the Siluron 2000 or 5000 to match the Siluron Xtra, and you will find a repeatedly reduced injection time by 34%. And that means that the molecular composition, which is the only difference, translates directly into easier surgical handling. You can then go to smaller gauges too, with a Siluron Xtra, which is the equivalent of a 5000 silicone oil. You can inject, if you inject it to 23 gauge, you will gain a third in injection time, but you can also now inject a 5000 oil equivalent through 25 gauge. If you try to do that with standard silicone oil, it will not work because it exceeds the machine's specifications. These are the pictures of emulsification as you all know it. However, as the silicone oil tends to break up into ever smaller droplets over time, it is not the visible, but the invisible emulsification which is responsible for inflammation, glaucoma, and fibrosis. And this is a picture, histological picture of trabecular meshwork that's been infiltrated by silicone oil bubbles. So it is the size between 1 and 30 micrometers that we are most concerned about. And there has been a problem in measuring this real emulsification. In order to measure this, we've borrowed from hematology, where the use of the Coulter counter is commonplace. It allows quantification and experimental proof of emulsification in an electrical field. And these results are also validated by microscope-based independent measuring methods. So if we look at real patients, real-world patients, this is a sample of silicone oil or the aqueous around it removed from a patient after 3 months. And you see that the oil droplets have broken up into ever smaller droplets, and you have a gathering here of high numbers of very small droplets in the 1 to 30 micrometer range. So what we see in emulsification with silicone oil has always been just the tip of the iceberg. We have a new measurement device, basically an organ on a chip, in this case an eye on a chip, which brings together novel manufacturing techniques such as 3D printing and 3D laser etching to produce the most accurate model of an eye so far. It is lined with retinal ganglion cells, which allows for the most accurate mimicry of the retinal surface so far. It also allows for separate circulation for aqueous, blood, and silicone oil. Novel microfluidics allow for the flow of very small amounts of fluid in a controlled fashion. In the top right corner, you can see the interface very clearly. The retinal ganglion cells are metabolically active, and they produce a substance which has a lower pH, and that changes color, and this can be seen as proof of viability of the cells. On the bottom left, you can see that microchannels allow for an accurate construction of the aqueous interface between silicone oil and retina. And on the bottom right, you can actually do full microscopy of the entire eye, as this is a closed system. We can make this a dynamic system by mounting the model eye onto a stepper motor, basically mimicking 90% of human saccades. In practice, what you find is that there is a strong reduction in emulsification droplet formation with rising high molecular additive. In 2000, and in particular in Siluron Xtra, where you maximize the anti-emulsification properties with higher viscosity. In the first of its kind human RCT on emulsification, Professor Stallmans compared Siluron 2000 to Siluron 5000, which is a standard silicone oil. It was used in macular hole cases which produce a repeatable environment for such a surgical study, as the oil was always removed at a set time, and it proved that Siluron 2000 is equivalent to a 5000 standard silicone oil with respect to emulsification. On the other hand, Siluron Xtra maximizes the emulsification resistance by having a higher shear viscosity, but in that case, you then obtain the lowest recorded in vitro emulsification rate so far. Clinically, we were struck by the clarity of the images. This patient has had Siluron 2000 in situ for 3 months, and yet it is very hard to show that this eye is oil-filled. We had to send him back for a picture to actually prove that there is silicone oil in this eye. This is the case of a 17-year-old patient who had 360-degree cryotherapy when he was a baby for retinopathy of prematurity. What this shows is a silicone oil-filled eye following vitrectomy and 360-degree retinectomy. It required this retinectomy to remove the crest entirely in order to be able to flatten the retina. The patient, as he had learning difficulties, could not attend his follow-up appointments, so he came back 5 months later. And we were struck by the clarity of the image, which is essentially the same as 10 days post-operatively. So in summary, Siluron 2000 is more resistant to emulsification compared to 1000, and it handles about the same as an experienced surgeon who uses 1000 silicone oil would be used to. The in vitro evidence suggests that Siluron Xtra is most resistant to emulsification and also takes significantly less time to inject than 5000 silicone oil. All of them are fully compatible with 25 gauge, and one oil in particular, Siluron Xtra, is an attractive proposition for all gauges. Most importantly, this novel technology allows for future improvements as well. So in summary, we've managed to create novel silicone oils which behave in a non-Newtonian way, in that they're visco-elastic and their behavior affords both faster surgery and injectability through smaller gauge instruments. Further clinical trials will determine whether the in vitro reduction of emulsification translates directly into reduced silicone oil-related complications. Thank you very much for your attention.